We'll also be having Dr. Chetan Shah from Mumbai, Dr. V.M. Kohli and Dr. Sashi Bala. May I request the chairpersons to invite Professor Nanda to set the ball rolling. And I believe incidentally he is not around, so we'll start the proceedings with Dr. Kapurr.
So it's an honor to present and call on Dr. K K Kapurr to present his first talk on coronary artery disease evaluation, and we might proceed to the second talk directly after this one to role of echo in evaluation of VT storm management. So please, Dr. Kapurr.
I'm just going to start. Just give me a minute. Thank you very much. I'll be speaking first on the role of 3D echo in the evaluation of coronary artery disease. I'll just take this out. Sorry for this. I was chairing the session and then I had to speak directly. Didn't get time to adjust this. Okay. I'll be speaking on the role of 3D echo in the evaluation of coronary artery disease, and we have to say that Dr. Nanda is a pioneer in 3D echo. The first reconstruction 3D echo was done in 1992 at his lab, and the first live 3D TE echo was performed in the year 2007 also in his lab. Now, what we look at the 3D echo as opposed to 2D echo, what are the advantages? And first of all, you have to say that a 2D echo is just a thin slice. 3D echo, therefore, is more likely to detect regional wall motion abnormality. The assessment of the global LV systolic function, including the end diastolic volume and the end systolic volumes and ejection fraction, is going to be more accurate by 3D echo as opposed to a 2D echo because of the absence of foreshortening and because of the absence of any geometric assumptions. Then we can get some idea on the coronary anatomy. We can, in some cases, with a reasonable echo window, get the proximal to the mid-segment of the coronary arteries on 3D echo, and we can also see the flow in them. 3D stress echocardiography is going to be very useful, and because of the fact that we can capture everything in one full volume study and therefore perform an immediate post-exercise 3D echocardiogram. We can also detect complications of myocardial infarction by 3D echo, and then we can have the integration of speckle strain imaging into 3D echo, the so-called 4D strain. Now, when we look at the global LV regional and global LV systolic function, the 3D echo allows us to have a better spatial relationship, therefore a better appreciation of regional wall motion abnormality. It allows us to perform any plane echocardiogram from a 3D volume data set, which I've already said. And a subtle wall motion abnormality at the LV apex or the LV infralateral wall could be identified, which may be otherwise missed on 2D echo, as is seen over here. That you get a 2D echo, there is no wall motion abnormality. On a 3D echo full volume study, there is a wall motion abnormality. This is another patient. Apical 4-chamber view does not show the wall motion abnormality, and a 3D echo shows the wall motion abnormality. Similarly, when you acquire 3D echo during stress, there will be a greater ability to detect transient wall motion abnormality immediately during the short time window available in the immediate post-exercise period, thus a potentially greater sensitivity to detect exercise ischemia. However, there is a problem. Relatively slow frame rate of 15 to 20 frames per second is a major limitation at a fast heart rate of more than 120 beats per minute. And as I said earlier, that the accurate quantification of LV ejection fraction is possible because of the absence of foreshortening, which avoids underestimation of the volumes, relatively operator independent, and with the contrast 3D echo, you can get endocardial enhancement, especially in patients with suboptimal acoustic windows. Now, this is some examples of the 3D contrast echocardiography. We use either Sonovue or Definity as a contrast, and we do a full acquisition obtained during stable contrast flow with no or minimal swirl of the contrast at the apex. And you can see the quality of study that you get on the unenhanced 3D echo image full volume versus a contrast enhanced 3D echo image. And therefore you can construct the endocardial shell by using this 3D echo full volume study, and you can get several short axis cuts, 9 short axis cuts you can get from one full volume study. And some of the examples of the short axis cuts: and you can get the computation of the LV and diastolic volume and systolic volume and ejection fraction. And there was a study which was done to show that during dobutamine stress, at peak stress, then when you do a contrast enhanced echo, the number of non-visualized segments are much less. Whether you take the apical 4-chamber view, the 2-chamber view, or the apical long axis view. In all of these, here are the percentage, the actual number of the unenhanced segments which are not adequately visualized, so cannot be categorized. And when you do the contrast enhanced imaging on the corresponding views, you find that you have a much lesser number of the non-visualized images. Now, these are some examples of the coronary arteries that you can crop from a pyramidal data set, and with appropriate angulation you can identify proximal to mid-coronary arteries. You can detect the plaques and coronary stenosis, and you can do the Enface imaging of the coronary arteries, and color velocity within the lumen helps in the assessment of stenosis, especially useful to identify or exclude significant proximal CAD or congenital coronary abnormalities. Now, this is an example of a normal left circumflex artery and a normal right coronary artery. This is from Dr. Nanda's book. And this is the LAD that is seen in the anterior interventricular groove. The LAD nicely seen in the anterior interventricular groove. And now you can see the left main is bifurcation into the circumflex and LAD, which are normal. But one of the marginal, the OM1 branch, was thought to be stenosis and was confirmed on angiogram. Similarly, you have over here also the branch, the OM1 branch, which was thought to be stenosis, and then you have the proximal RCA stenosis here. This is the right coronary artery, and this is the proximal RCA stenosis, and this is the normal left main and the circumflex artery and the marginal arteries. And then you can put the color flow, and by lowering the scale of the color flow and altering the baseline of the color flow, you can get the flows in the left main coronary artery and from the LAD and of the diagonal coronary arteries, and you can see it even in the LAD, which is just adjacent to the anterior IVS. Now you can get LV apical clot, which may sometimes be missed on 2D echo, because if you do not take, especially if you do not take adequate planes, you can miss a 2D apical clot, as we can show, and then potentially life-threatening complications of after myocardial infarction are better picked up like the ventricular septal rupture, papillary muscle rupture, and free wall apical rupture, which helps in the management of the patients, which helps in the surgical management of the patients. Now, if we can take the example here of an LV apical clot, which is so nicely seen over here, and we do detect some areas of clot lysis in it, and this is an example where there was no clot seen on apical 4 because an appropriate apical tilt was not given. But on 3D echo, you can see a nice clot at the LV apex. You can see a nice clot at the LV apex on 3D echo. Similarly, again, the apical 4 chamber view does not show the clot, but a tilted apical 2 chambers just show a clot, which is also seen on the 3D echo. Now this is an example of an apical rupture with a clot, and you can see a pseudoaneurysm with a narrow neck, and you can see the clot over here, and you can see the clot inside, and when you crop it, you find that there were no areas of clot lysis. And this is an example of an apical septal rupture on 3D echo. You can see the LV and RV, and when you view it and fast from the LV side or from the RV side, you can see the VSD post myocardial infarction. And then when the patch repair has been done in a patient with a post MI VSD, what you can see over here is a dehiscence of the patch, and you can see the communication, the original site of the rupture of the IVS between the RV and the LV, that is after the patch, and because of the patch dehiscence, there was leakage of blood into this chamber, apical chamber, and then into the right ventricle through the VSD. Now this is an example of the flow into the apical chamber, as you can see it end on. Now other advantage of 3D echo is that we can now do the 3D strain. Now the strain can also be performed by tissue Doppler, but it is limited by angle dependency, and 2D strain is angle independent but tracks the myocardial motion in 2 dimensions only. The motion of the myocardium in the 3rd dimension is not tracked, and this affects the quality and accuracy of speckle tracking. The integration of speckle tracking into 3D echo allows quantification of different types of strains in all dimensions. These are the velocity vectors in 3 dimensions, and there you can get a circumferential and the longitudinal strain. And you can also see after this is a patient with a right coronary involvement having the loss of the strain in this region using the polar map and using the parametric imaging for the displacement parameter. You can see that there is a dyskinesis of the apex and hypokinesis of the IVS and the distal part of the left ventricle, and these are the different types of strains that can be got on 4D strain, the apical twist and torsion. Thank you very much.
Thank you, Dr. Kapurr. We are continuing with the 3G Symposium, and it's an honor to present Dr. Naveen Nanda to tell us where are we today.